Assalamu alaikum warahmatullahi wabarakatuh. A very good evening to all the medical fraternities from Middle East and Asia, and a very good morning to all from Europe. We have joined us online for today's annual convention webinar, Bronchopulmonary Dysplasia, organized by IAP Emirates Neonatal Chapter in affiliation with Zahra Hospital Sharjah and Vertebratics in Kizi from New Country Healthcare. Myself, Tawfiq Ali, Country Business Manager of New Country Healthcare. Today we have the best of the best speakers on BPD, and I have with me online the office bearers of IAP Emirates Neonatal Chapter, Dr. Rajiv PK, President, Dr. Sridhar Kalyan Sundaram, Secretary, Dr. Rajesh Sharma, Treasurer, Dr. Monica Kaushal, President-elect, Dr. Jaishila Kannan from Zara Hospital Sharjah, and Dr. Lilian Maher, the Brand Manager of Kizi Pharmacy TC. Before starting, I would like to play national anthem of UAE in respect for this wonderful country. So once the anthem is over, Dr. Rajiv, please come up and take over the proceedings. Mr. Fadi, can we have the national anthem, please? Thank you, Fadi. Dr. Rajiv, if you can take over the proceedings, please.
Start with. Can you put my video on? Okay, now. Good evening, everybody. On this auspicious occasion of our Indian Academy Pediatric Emirates Neonatal Chapter, I welcome you all to this August conference. And I'm most honored to have my teacher and one of the pioneers in newborn care in the world, Dr. Dharmapuri Vidyasagar. He has seen neonatal care from the 70s and is one of the pillars of neonatal care in USA. And we are very happy to have him with us to start with the inaugural address. Dr. Sagar, over to you. We are very happy to have you with us today.
Rick?
Yes, Dr. Dharmapuri.
Yes.
Yes.
Good morning. Assalamu alaikum for all the friends in Middle East. And hello to everybody around the world. Can you hear me?
Yes, Doctor.
Okay. It's indeed a great pleasure for me to participate in this conference and welcome all our friends around the globe. Rajiv has done a fantastic job in putting us together. Next slide, please. My first encounter with Rajiv was about 25 years ago in December of 1995 when we met together in the city of Kochi in Kerala, in India, to conduct a international neonatal conference. The distinguished speakers included Vinny Bhutani, Carlo Vladimir, Sunil Sinha, Dr. Amil Tisan, and a number of other people. And that initiated our friendship. Next slide. And continues today. Next slide, please. Now, this is a nostalgic photograph of that meeting where Rajiv, young man here, and myself and Dr. Bhutani here, inaugurating our first conference. Next slide, please. So Rajiv has been energetically pursuing his passion of teaching and improving neonatal care in India, particularly focusing on neonatal ventilation. During this period, he has edited a couple of books on CPAP and ventilation. Most recently, we published a neonatal ventilation along with myself and Dr. Nursimhan, and that has gone very well around the world, introducing to people the science and art of ventilation. After 25 years of academic and personal camaraderie and friendship, it is my pleasure today to inaugurate the symposium on BPD that Rajiv is sponsoring under his leadership. Next slide, please. Today, the symposium topic of BPD starts with a short retrospective view of the history of modern neonatal intensive care, because this will give the background for young neonatologists where we started and how we started. Starting in 1955, when the neonatal intensive care was a totally innovative subject, and then which progressed to, in a number of areas, to decrease neonatal mortality during the last 7 decades of decades as shown in the next slide, please. This is a busy slide published once by March of Dimes. It shows you by year, starting at the 1900 onwards, with a break here, number of progress has been made in various issues of obstetric and perinatology, neonatal thermal control, nutrition, and ventilation. And here you see the two lines of showing the neonatal mortality rates both in UK and USA. We can see a steady decrease in neonatal ventilation and neonatal mortality with time and with the progress in science in various fields. So by this slide was made up to 2010, and it has dropped to 5 per thousand or so. And of course, if you draw the line further, you will see not only the decrease in neonatal mortality, but also number of other issues we have improved quite a deal. Next slide, please. The earlier experience in coming to having established neonatal intensive care, there was a need to improve the outcome of the babies, particularly premature babies who had a respiratory distress syndrome, respiratory difficulties. So we had to initiate neonatal ventilation. There are many studies or initial experiences that have been described in a number of papers, but the initial experience with mechanical ventilation were not encouraging, and they were fraught with a very low survival rate. The first highly successful ventilatory support, however, was reported by premature infants by late Dr. Maria de Livoria Papadopoulos in 1965, who reported out of 20 babies with a severe hyaline membrane disease, she ventilated, 7 survived, and 6 of them were neurologically intact in later examination. Next, this was one of the most encouraging report. Next slide, please. From later in 1968, a conference was held under the sponsorship of Ross on neonatal intensive care in USA, and various speakers from different parts of North America, made presentations. They showed that impact of intensive care on improved survival and complications, long-term intact survival were reported at that point. They showed that survival with assisted ventilation was highest among infants with a tetanus who had no lung disease, which reversed an 80% mortality down to 80% survival. On the other hand, survival rate in premature babies with hyaline membrane disease, although was improving, it was still low in 28 to 30%. The results of assisted ventilation and other respiratory conditions were not very encouraging. Next slide, please. At this time, Dr. Lucy, who was chairman of the conference, summarized the symposium as follows. Now that you have read the proceedings of this conference, some will be frustrated and discouraged. Others will be encouraged to try to improve the care in neonatal in their own nursery. Hopefully, this conference will have supplied with early but firm data to encourage you in these efforts and warn you of the problems involved and caution. What is she saying? Whereas intensive care is effective, we still do not have a clear idea about the key elements of success. The construction of a new nursery for the purchase of a blood gas machine and a respirator do not make an intensive care nursery. But the key elements of intelligent personnel are, as one participant said, people who care intensively. So this slide tells us that even in 1968, the experience across the USA has shown that there was some improvement in neonatal intensive care, babies who are ventilated, but it was very clear it is not the machine alone, but we need to have people, well-trained nursing staff and personnel to manage these babies. Next slide, please. So the concept of neonatal intensive care was based not just on the machines, but on the trained personnel. In a later conference, following year, 1969, conference was held in Paris under the leadership of Dr. Minkowski and various speakers around the Europe and America joined there to present their experiences in neonatal ventilation. So they raised the question whether neonatologists should continue to provide assisted ventilation, perhaps more aggressively, or whether possible complications of ventilation outweigh the neonatal ventilation. History shows, following that conference, history shows that successive pioneer neonatologists chose the former, that is, starting aggressive ventilation and challenges, and continue to improve the science and art of neonatal ventilation with great success, stretching the limits of survival even in the extremely low gestation infants, as you will see the results later on. Yes, in the process, we encountered many complications which are being ameliorated. However, BPD remains as one of the major complications which is the subject of discussion today. Next slide, please. I should say that many of these workers, pioneers in the field, including Dr. Bankalari and a number of other people following that, Dr. Vinit Bhandari, who've been doing a lot of work in this field, are going to share the information with us. But I can very well relate to Eduardo because we both belong to the same age group. Here is a slide. Most recent information you see is by Stahl. She analyzed the data from NICHD and extremely premature babies. What she shows in these slides is during the last 60, 70 years, there has been a tremendous improvement in antenatal and postnatal interventions, such as antenatal steroids, which started in 1970s, and use of antenatal antibiotics, cesarean section even for the premature babies, delivery room intubation, surfactant therapy introduced by Dr. Fujiwara in 1980s, and postnatal steroid treatment. So these are the various interventions that have been introduced both antenatally and postnatally. Next slide, please. What is the impact? The impact is the current survival in the extremely low birth weight infants, I've seen even up to 22 weeks, 23 weeks, is steadily improving. You can see here in 23-week gestation, survival 40% here. Now, with each week of gestation, you can see gestation in 24-week gestation, babies survival have gone up to 60%, and 25-week gestation about 80%. And with the, you can see in 28 weeks is almost 90 to 100%. Next slide. But one of the problem we have been seeing, the impact on associated morbidities is continue to remain. But one good news is complications of, can you load the slides a little bit? The PBL and various complications have decreased, but the BPD continues to rise. The more the babies in an extreme premature babies survive, the BPD, bronchopulmonary dysplasia, continues to remain high. Next slide, please. So the remaining questions for us are, what are our new understandings of the development of BPD? What are the optimal treatment modalities to prevent and to manage BPD? And what are the long-term outcomes of infants surviving BPD? Finally, can we prevent bronchopulmonary dysplasia? Next slide, please. So, in conclusion, the organizers have put together, assembled renowned researchers such as Eduardo and Vineet Bhandari and many other colleagues on the panel today, and master clinicians who have really excelled in the management of extremely premature babies, to update us with information regarding the previous questions which form the basis of BPD, and with the current treatment modalities and long-term clinical outcomes. Yet, they will carry the burden of BPD related to into the later life. As recently, I should make a statement, paraphrase the statement by Kamala Harris, the Vivian Harris, the Vice President of America. She said, we not only dream of things, but we do. Same way, we not only see what has been done, as we have seen so far in neonatal ventilation, but we see what can be done. I think our speakers are in a very good position to tell us what we can do in future, what the future looks for the premature baby in year 2000 onwards, 2020 and onwards. I'm sure you will enjoy their symposium, and wish you all a very healthy year of 2021, free of COVID, and hope we'll be moving much more freely and have a meeting in person somewhere in a nice place. Thank you very much.
Thank you very much, Dr. Sagar. So I request Dr. Sunny to give the welcome address now.
Friends, good evening, assalamu alaikum everyone. Whether it is good morning somewhere, good afternoon, good evening, it's really wonderful that we have got more than 1,000 registrations. And I really at this juncture on behalf of IAP Emirates, appreciate the efforts of Dr. Rajiv, Dr. Monica, Dr. Sridhar, Dr. Rajesh, and the entire team to have cooked up such a wonderful program for today. When I was looking at the list of the faculty, it is really mouth-watering, for a postgraduate, for a student, for a practitioner to have such an esteemed faculty. It's really wonderful. And a subject like BPD and the 40 years journey of this particular problem, I think I'm just waiting to hear from them. it was, I mean, for me, the best option would have been to meet these people in person, but the next best thing is to have them on a virtual platform. Hopefully, like Dr. Sagar said, in the very near future, once COVID is taken care of, we can have a personal meeting and interact with all these doyens in the field of neonatology. One other thing that I just thought of when I was listening to Dr. Sagar is that the man behind the machines. I think the professors and the doyens from the subcontinent can be proud that in the Middle East, especially in Dubai, most of the hospitals, most of the neonatology hospitals are headed by their students, their proteges, and they are making their professors very proud. A brief word about Rajiv. I was tempted to mention this because I heard from Dr. Sagar and his associate of 1995. I know Dr. Rajiv, and I really appreciate his single-handed effort to get this particular program over and done with. It's a real feather in the cap for this chapter. This is the most active chapter of IAP Emirates, the neonatology chapter. I expect a lot of good things from them, and I see that each one of them is so persistent and so dedicated to get this program going. I don't want to be in the way. I wish everyone success. We are going to have a virtual feast over the next few hours, where we are all eagerly waiting to hear from the experts in the field. I once again welcome all of you all. I don't want to carry my speech any further because there are so many interesting topics coming up. Have a great evening. Thank you.
Thank you very much, Dr. Sani, for this wonderful welcome address. So I'd like to request Dr. Sridhar to give an introduction to the moderators today.
Good evening, everyone. Thank you, Taufik, for helping with the organizing, and congratulations, Dr. Rajiv, for this excellent effort and putting up such a great program. So we have a real feast, as Dr. Vidyasagar and Dr. Sani have already mentioned. I don't want to repeat the same thing. We also have great faculty here to moderate the sessions today. So we have Dr. Junaid Khan, whom all of you know. He's the consultant neonatologist, and he's currently at Abu Dhabi. And Dr. Ayman Rahmani, he's head of neonatology at Tawam Hospital. We have Dr. Mahmoud Al-Halik, who is a consultant neonatologist and head of neonatology at Latifa Hospital. And we have Dr. Khalid Datavi, who is also a well-known neonatologist in the region. He's a consultant neonatologist at Latifa Hospital as well. We also have Dr. Rajiv, who will join them as a moderator. So we have an excellent session waiting, and congratulations again to the team who has put up a great show. Thank you, Taufik, again. I hand over to Taufik and Dr. Rajiv to continue the show. Thank you.
Thank you very much, Dr. Sridhar. So I'd request Dr. Ayman Rahmani to introduce our first speaker, Dr. Patrick.
Good morning, everybody. Good afternoon, those of you in UAE. It's a pleasure to be part of the faculty of this excellent seminar. It gives me a great honor and privilege to introduce the first speaker of this session, Dr. Patrick McNamara. He's coming to us from University of Iowa. Dr. McNamara is Chief of Division of Neonatal Medicine and Professor of Pediatrics and Internal Medicine at University of Iowa. He has a long resume. He currently is the chair of Pan American Hemodynamic Collaborative and Pediatric Academy Society of Neonatal Hemodynamic Advisory and Neonatal Hemodynamics. He has special interest in the American Society of Echocardiography. His clinical research interests include myocardial performance in the setting of hemodynamics with significant ductus arteriosus and pulmonary hypertension and targeted neonatal echocardiography. He has published over 300 peer-review publications, chapters, and other works. He's going to tackle a very difficult topic that we face in everyday practice of neonatology, which is the hemodynamic management of PDA, and to add to this difficulty in the context of BPD. It's my privilege to introduce Dr. Patrick McNamara.
Good morning, Ayman. Can you see the slides?
Yes, I can see it.
Okay, perfect. Okay, so thank you everyone for this wonderful invitation, and I applaud the organizers for putting together kind of a very thoughtful program. I also applaud them for what I would say somewhat precedent setting of reminding everyone that what happens in the lung is not just about the lung. And I think as we move into the kind of the current era of neonatology, I think it's increasingly becoming recognized that if we are to provide the optimal care, we need to think of patients in a much more holistic manner. We got to recognize the relationship between heart, brain, lungs, and so forth, and in particular the modulator role from a BPD perspective of the heart in terms of kind of the findings that we actually see. So with respect to the ductus arteriosus, it's unbelievable that it's long before I was born. 1956 was the very first report by Mostyn Powell that premature infants with an ongoing ductus arteriosus get respiratory symptomatology. And if we look at the time I started off neonatology, which was 1997, doing training in the UK, at that point in time, if you look at the contemporary literature, it looks like we had solved the problem. Trials of early surgery showed a reduction in both lung injury and bowel injury. And the trials of medical therapy, and this is Ron Kleiman's meta-analysis at the time, suggested that the earlier you intervene, the more likely you are to have a reduction both in respiratory and bowel morbidity. But if you look at the year 2020, 21, a lot has changed over the last 15 years. And if you look at the graph on the right-hand side, and this is data from the Canadian Neonatal Network, where I had the privilege to work at SickKids until 2018, you can see that kind of the last 10 to 15 years have been dominated by a secular movement away from both medical and surgical therapy and an increase in this concept of conservative therapy. The fundamental question today is this the appropriate way to manage these patients? And then for the specific purposes of the talk today, how might these secular changes impact our rates of chronic lung disease? If you look at the data and you look at potentially the reasons why physicians have moved away from, I would say, aggressive intervention. First, there are data that spontaneous closure occurs. And if you look at bigger babies over 1,200 grams, what you can see is the vast majority of those infants by 3 weeks of life will have spontaneous closure. However, if you look at babies under 750 grams who really reflect the highest risk patients of all neonatal morbidity, the fundamental question to be asked is exposure of over half of these babies to an average of more than 50 days an acceptable risk? The second question one needs to ask is, how does spontaneous closure occur? And we actually have no idea how does spontaneous closure occur in these babies. Is it, we assume, a process of natural remodeling? And again, bear in mind that the immature ductus is very different in its architecture to the term ductus. It's got less muscle, it doesn't have vasa vasorum and so forth, which raises the question, is closure through another mechanism, through augmentation in pulmonary vascular resistance, through remodeling of the pulmonary vessels, are we leading to a reduction in net flow across the ductus through the differential pressure gradient across the PDA? If this was the case, that would be concerning. The second reason, and probably the most compelling reason that has moved the field away from kind of aggressive intervention, is Bill Bennett's meta-analysis, which basically shows whether it's medical or surgical therapy, treatment closes the PDA, but based on these trials, there was no difference in any of the neonatal morbidities including lung disease. So how do we think about this contemporary literature? Well, I recently gave a talk at the IAP meeting, and one of the trainees presented a case of a 1-month-old infant who is dependent on a ventilator with a moderate size PDA and left to right shunt. And I was asked the question, would I surgically close this ductus? And my answer was, I don't know. I don't have enough information. All you're telling me is that the ductus is patent. They proceeded to say that then the baby developed some subjective increase in left heart volume loading using the LA to AO ratio. Again, I'm uncertain. And part of the reason for the uncertainty is we know from imaging data that subjective assessment of size of vessel, size of chamber is highly unreliable, with kappa coefficients as low as 0.2 for many of these measurements. Which gets us to the fundamental question when we look at the trials, and I think it's incredibly important that when we think about evidence, we think about evidence in terms of, is it relevant to practice today? And based on the way in which we evaluate the problem, was there diagnostic homogeneity, and did we truly appraise the problem in the trials? The second question we need to ask is, who were the control patients? And ultimately, and I think this is the holy grail, and if anything, I think the data from the past has certainly taught us that extremes in practice are probably not good. So if we look at imaging data, so this is Kurt Duval's meta-analysis of all the trials, up to 40% of the randomized trials did not have echo. Secondly, and this is an image here, and this is Dr. Ed Bell, who is one of my colleagues and former kind of leader in the field. And this is Ed in the 1970s using echocardiography. But why I put this picture up is that the tools available in the 70s and the 80s were not very good compared to what we have available today. So image quality is fundamental to all imaging-based research analysis. And the reason for that is, again, across the world, the standard by which people adjudicate whether or not to intervene for the ductus is basically the size of the vessel. And in the image on the right-hand side here, you can see this nice red jet, which reflects a left to right shunt. However, if your image quality is poor or the operator is inexperienced, there may be operator and equipment dependent error. And when we looked at a whole range of echo parameters that tell us about shunt volume, the two measurements with the highest degree of inter-rater reliability issues were PDA diameter and the LA to AO ratio, which unfortunately reflects the standard of care in most programs because most people are reliant on pediatric cardiology to provide these evaluations. So it's not surprising when you look, and this is some work that Fernando Martins did with us when he did his PhD in Toronto kind of about 5 years ago, when you look at the relationship of diameter, whether it's indexed or not, to all of these markers that tell you, is there fundamental dysregulation in either pulmonary blood flow or systemic blood flow, you can see that the R-squared values are low. And that doesn't mean that diameter is not important, but what it's telling us is that flow is not just dependent on diameter, it's dependent on many other things, which we will come back to. The other reason where a singular focus potentially is problematic is that we are looking at a three-dimensional structure and making a two-dimensional interpretation. And if you look at these images here, these PDAs come in all sorts of different shapes and sizes. Straight through is the classic cylindric-shaped PDAs, but we have funnel-shaped PDAs, serpentine-shaped PDAs. And why this is relevant is our assumption is when we take a single plane assessment of the vessel, we're assuming in cross-section that it is circular. The images on the right-hand side are pathological reconstructions of vessels from postmortem. And what you can see is that the shape of the ductus in cross-section is highly variable. And why that's relevant is if you take the second picture at the top here, you may have overestimation or significant underestimation of the size of this vessel based on wherever your imaging plane is. So we need to move beyond single point estimates. The second major reason for concern with looking at contemporary data is, unfortunately, we really have not done the desired trial, which is to identify patients who have the most problematic shunts and randomize them to intervention and not provide intervention for a substantial period of time in the control group. Even the PDA Tolerate trial, there was up to 63% of patients receive medical therapy. So in essence, what we've done in the trials is we've compared treatment to treatment at another point in time. And the final thing, I think that two final points that I think are incredibly important with respect to interrogation of the literature is the data contemporary? And if you actually look at the studies that constituted Bill's meta-analysis, the median year of publication was 1994, which is prior to me even starting off in neonatology. And this is highly relevant because if you think of in 1994, we did not have 22 and 23 weekers surviving. We did not have nitric oxide. We had different ventilators, equipment, and so forth. So one can argue that for the baby in 2021, these data probably don't help us, and these trials probably should be expired. The other fundamental concern, and something that has not really been articulated well, is that when you look particularly at medical trials, one of the unfortunate consequences of medical therapy is that medical therapy doesn't always work, and we don't necessarily adjust for that. The final point I want to make with respect to the literature is the issue of equipoise. We assume in trials that the patients randomized are comparable to the patients that we're currently looking after. This is a post hoc study of the PDA Tolerate trial that Melissa and Ron published. Up to 35% of the patients who were eligible were not enrolled. And the reason they were not enrolled was because of physician equipoise. Those babies were younger, those babies were smaller, sicker, less likely to have antenatal steroids. But interestingly, those babies were treated and treated early. And their rates of the composite outcome of death or BPD were significantly enhanced, suggesting that perhaps we really are not or have not studied the patients of interest. So why do we need to think about the lung? And why is it important in defining population of interest? Well, if you look at patients that have a large amount of blood flowing across the ductus, the two consequences are excessive pulmonary blood flow and systemic hypoperfusion. Excessive pulmonary blood flow, just like our babies with congenital heart disease, single ventricular physiology, will lead to alterations in lung compliance, prolonged ventilation, and so forth. And if we think of BPD, and again, I am not an expert on BPD and do not claim to be an expert on BPD, but we know that the BPD is really a physiologic continuum, but that physiologic continuum is not just about lung parenchyma. It's also about the pulmonary vascular bed. And there are many, many potential determinants ranging from the classic risk factors of fetal inflammation to prolonged ventilation and oxygen and so forth. But the ductus has been, for a long time, recognized as an important association. So why might this association be important, and what might be the key factors if we're to think of the ductus in a much more thoughtful manner? And I believe the key factors are two things. One, what is the magnitude of the shunt? There are some patients, perhaps, who have very low volume shunts in which there really is a negligible impact, but perhaps high volume shunts and high volume shunts that are prolonged may be more relevant. And what are the biological factors that may be relevant with respect to the lung? Well, one is excessive blood flow, and the second is excessive blood that is at a much higher PO2, and we'll come back to this in a moment. The second reason you may be worried is pulmonary venous hypertension and the impact from a back pressure perspective and a loading of the left heart on the immature lung. So in the face of pulmonary overcirculation, and again, if we draw parallels from our patients with congenital heart disease, the potential for intimal thickening, medial wall hypertrophy, leading to pulmonary arterial hypertension, has biological plausibility, but is there any evidence of this? Well, I'm sad to say there is, but it's really, really old. We've actually known since 1953 that this is a study of young adults with prolonged exposure to PDAs, and they report in this study fairly significant increased muscularization of the pulmonary vascular bed. And why this is incredibly important, and one of the concepts that we push in hemodynamics is the importance of physiologic and phenotypic profiling. And in the subpopulation of patients with BPD who have chronic pulmonary hypertension, it's important to recognize that elevated pressure is the combination of flow times resistance. And we typically think of resistance in isolation of flow. But if you think of our chronic patient population, many of them may have chronic shunts, not just PDA, but also the role of the atrial septal shunt. And if this is what's driving pressure, then you need to modulate flow. Versus other populations, such as those with downstream systemic hypertension, who may have a post-capillary pulmonary vascular disease that may require systemic vasodilation. So the relevance of the ductus to not just BPD, but chronic pulmonary hypertension is important to recognize. So why biologically is important? Well, nobody here will question the relevance of excessive oxygen to the immature lung. There's both animal data and human data that, this is some data from a rodent model that shows significant increase in both fibrosis, impaired alveologenesis, and increased pulmonary vascular bed, muscle thickening. However, as mentioned before, one of the phenotypes of PDA is excessive pulmonary blood flow. And here, just to show you an example, the image on the left is pulmonary vein flow in a patient with a closed duct. You can see the peak velocity is around 0.3. Look at this patient here who has a torrential PDA shunt. There's almost a trebling of pulmonary venous return. And it's important to remember that the lung is exposed to blood with a higher PO2. So in our aspirations to minimize oxygen exposure, the presence of a big shunt is actually delivering much more oxygenated blood to the lung. So what evidence do we have of the impact to the immature lung? The image on the left is from the primate model, and this is a study in which they closed the ductus early, and you can see that QPQS normalizes in the patients in whom the ductus was eliminated. Those patients had got lower lung compliance. Interestingly, the patients with prolonged exposure to high volume shunts with increased QPQS also had abnormal lung compliance. But of more interest, when they looked at the lungs of these patients at 36 weeks gestation, what they actually found was that there was an increase in alveolar simplification, fibrosis, but also an increase in muscularization, suggesting that in the primate model, which really is the one that reflects the human physiology, prolonged exposure to shunts that cause major dysregulation to QPQS is probably not a good thing. What evidence do we have from humans? Well, this is a study we conducted in Toronto around 2015, where we looked at the worst shunts, and we looked specifically at patients who had prolonged shunts that ultimately needed surgical ligation versus prolonged shunts in which medical therapy was successful. And what you can see is that the ligation population had much higher respiratory requirements. This is mean airway pressure. The FiO2 and respiratory severity scores were also very similar. But most interestingly, if you track this back as early as the first 2 to 3 days of life, you can see that there's separation. These patients had higher respiratory requirements even in the transitional period, which may be important, and we'll come back to this. So in 2007, we published this Sentinel paper, Arvind Sehgal and I, in which we basically said that we need to think of this problem beyond ductal size. We need to recognize that there are situations, in which if you close the duct, you're probably going to harm the patient. There may be heart dysfunction, there may be pulmonary hypertension, in which the ductus has a biologically important role. We're interested in patients who have big shunts that are leading to physiologic dysregulation, and those perhaps are the patients we need to target. So we propose this model that assessment should not just be about PDA size and directionality, but we need to measure many things that collectively tell us that there's increased QPQS, there's loading of the pulmonary circulation, loading of the left heart, and there's compromise to systemic hypoperfusion. And some people have argued, why do we make this so complicated? Well, I would argue that medicine is about precision. It's about making the right decision. The more superficial the assessment, the less likely you are to be diagnostically precise that there's a particular problem. And PDA physiology is all about volume of flow and having a collection of markers that have the same directionality. So if many of these markers tell you that there's physiologic disturbance, you're more likely to believe that the shunt is a problem. So do we have any evidence that scoring or staging the system has got some value? And we actually do. This was probably the first study that Arvind published kind of around 2010, where he looked at a small cohort and basically looked at high-grade shunts, which would be classified kind of based on that criterion as kind of the C3, E3, C4, E4 type shunts. And those shunts were associated with prolonged exposure to oxygen and a trend towards increase in BPD. We did not look at chronic pulmonary hypertension in these patients. This data was also subsequently studied in another patient population, and this is the work from the Italian group Shane et al., where they also demonstrated that the presence of a high-grade shunt, E3, E4, was a strong predictor of BPD. And this data is fairly telling, and they basically reported that for every day you have exposure to a very high volume shunt, the risk of BPD increased by 8%. So on a weekly basis, that risk was 70%. Again, observational data, however, suggesting that prolonged exposure to the highest volume shunt is probably what we're interested in. And that concept was then recently further kind of emphasized by another post hoc analysis of Ron Kleiman's PDA Tolerate trial, where they basically showed that in the intubated patients who required prolonged intubation, who reflect probably a higher risk patient population clinically, who had more prolonged exposure to high volume shunts, there was an increasing relationship with duration of exposure to the more severe forms of BPD. Very briefly, and again, just to drift, but just to further emphasize the importance of prolonged exposure, I just want to share with you, and I know recently many of you will have heard from kind of my colleague John Klein about the Iowa data on tiny babies, and I'm very privileged to lead this program where we have exceptional survival rates at 22 and 23 weeks. But one of the things we were interested in over the last couple of years is to look at the relationship between prolonged exposure to retinopathy of prematurity. And part of the reason for this study, very similar to the lung, it's important to recognize that the eye is perfused by preductal cardiac output. And as you already know, cardiac output will increase with increasing volume of shunt. So the eye, in essence, is exposed to more blood, but more blood with a higher PO2. And interestingly, when we looked at the relationship between the composite outcome of death or severe ROP or ROP in survivors, PDA shunt and high volume shunt was a very strong associated after adjustment for all of these factors here, such that a PDA score of 78, and we'll come back to this later on, which reflects 7 days of exposure to a high volume shunt, predicted ROP with a very high sensitivity and specificity. So prolonged exposure is important. So what is the optimal time of intervention, and how do we move from where we are today? Well, currently the IAP statement suggests that early routine treatment to induce closure in the first 2 weeks does not improve long-term outcomes. Now, I would argue that this statement is very much based on previous trials that probably should be expired, that don't really help us answer this question. The fundamental thing one needs to think about is that there are entities like intraventricular hemorrhage, hypotension, pulmonary hemorrhage, which has been strongly associated with PDA, if you intervene beyond day 7, you're not going to be able to modulate any of these outcomes. Entities like NEC, BPD, which have also been associated with PDA exposure, are confounded by many things like infection, other morbidities that happen. So that the concept is perhaps we need to think about, if we are to strive to minimize these problems, perhaps we need to think a little bit earlier. So what evidence do we have that the early ductus is a problem? Well, this is a Danish study that I had the privilege to collaborate with, where they basically showed that the presence of a large PDA on day 3 of life was associated with an increase in both mortality, severe IVH, and necrotizing enterocolitis. The problem with early assessment is that it's imprecise. Parameters such as heart murmur, pulse pressure really don't help you solve this problem. This is a nice study from a UK group where they looked at patients who had big shunts after day 7 recognized. And what they did was they looked at the clinical parameters in the first week of life that predicted late treatment. The only parameter that was associated with late treatment was metabolic acidosis. And certainly in our experience, metabolic acidosis is an important determinant, obviously, of appraisal of the inadequacy of systemic hypoperfusion. But most of the parameters that we see fall into these categories: worsening ventilation, increasing FiO2, hypotension, metabolic acidosis. You can manage these things from a symptom-based perspective, but neonatology needs to move away from symptom-based care to think more about diagnostic precision. And these constellation of symptoms may reflect PDA, but may also reflect pulmonary hypertension, heart dysfunction, sepsis. And our goal is to provide not just care, but to provide the best care, which requires the highest degree of diagnostic precision. It becomes very difficult when you're trying to look at the relationship between outcomes and symptoms. And we've learned this lesson from hypotension, for example. Better ways to do this are to define the phenotypes and look at the relationship between phenotypes and outcomes. So one of the other arguments in the IAP statement was that the ductus is not a problem biologically and physiologically in the first week of life because pulmonary vascular resistance is elevated. This has not been our experience. This is a baby who is 6 hours old, and even by 6 hours, you can see the flow is all left to right. There's very marked dilation of the left heart, and there's compromise to postductal flow with an increase in reversal in the postductal arch, which is one of the most sensitive markers of shunt volume. This concept that the ductus truly is an issue early on was reiterated by another UK study where they did an echo which was blinded to the clinicians in the first 24 hours of life. And they then looked at the relationship between late treatment and the findings of that echo. And what they basically found was that patients who ultimately required therapy beyond day 7 had large PDAs on day 1 of life. So what does that mean? Well, if you look at, and this is an observational study we conducted both in Canada and Ireland with Afif Al-Kafash, what we can see is that there's 2 categories of patients. There are some babies who have large PDAs on day 1 that will close spontaneously. There are others that stay open. But the most telling findings here is that those babies identify themselves biologically. As pulmonary vascular resistance falls, the shunt volume will increase. And what you can see here is those patients, as early as the first 24 to 48 hours, have high flow in the pulmonary veins, have high left ventricular output that continues to rise, and they already have compromised diastolic flow to the descending arch, to the bow, and also to the brain, suggesting that early echocardiography can help identify subpopulations at increased risk of abnormal profiles. And in this same paper, we looked at the relationship between a composite of echo markers, and this particular score was strongly associated with the composite outcome of death or BPD, such that a score more than 6 predicted this risk with a high sensitivity and specificity. It's important to look comprehensively, and once upon a time, we thought that the atrial septum may actually inhibit the reliability of the echo. We recently just published a paper in JIST actually suggests the opposite, that the atrial shunt is actually probably a physiological manifestation of bigger PDA shunts. And what you can see here is patients who have, in the first few days of life, larger PDAs and larger atrial communications actually have the highest volume of shunts. Pulmonary vein flow, cardiac output, compromised flow to the descending arch were all much more pathologic in the presence of a large atrial communication, suggesting that an atrial communication in the presence of a PDA is another echo marker of hemodynamic significance. And what further adds to the argument and to the interest here is when we looked at the relationship of kind of PDA score, PDA diameter, and also atrial communication to the risk of BPD or death, the presence of a large atrial communication in the first few days of life is an important parameter that we need to take care of and need to think about. So now thinking about what modulates flow, and I think this is one of the most underappreciated concepts with respect to PDA. We traditionally have thought of PDA closure in terms of giving drugs to close the ductus, but flow is determined not just by size of the vessel, although that's very important. It's cubed. Pressure difference, viscosity, and length also will increase the magnitude of the shunt. So what evidence do we have of early intervention that it may be beneficial? Well, probably the best study are the trials of prophylactic indomethacin, which show a reduction in surgical ligation and a reduction in severe hemorrhage. However, there was no improvement in long-term neurodevelopmental outcome. The question that remains is, well, how was indomethacin efficacious? Was this PDA dependent or PDA independent? And it's a highly controversial area. However, I would argue that from a biological perspective, an intervention that has a very short-term effect is highly unlikely to stabilize the germinal matrix of the brain. And there may be other factors at play here that influence this relationship. The other thing that's important is, why did it not improve neurodevelopmental outcome? Was there something about giving indomethacin that could potentially have harmed other patients? We have definitely some data, again, it's very old data. This is Bob Cotton's original study, which basically showed that early closure also surgically was associated with improved respiratory outcomes. However, again, this is 1978. The relevance today is highly questionable. One of the most important questions to me is what happens when you stop using prophylactic indomethacin. And this is some of the UCSF data. If you focus on the top left graph in babies who are less than 25 weeks gestation, here is arrow 1. You can see the rates of prolonged PDA exposure beyond day 7 of life were only 10 to 15%. When they stopped using prophylactic indomethacin, you can see that by day 7, 80% of shunts were still large, although that number with medical therapy did close kind of over time. But the most important factor is when they looked at the relationship between PDA, and this is just size, and versus PDA constriction, patients who had large PDAs on day 7 had twice the risk of BPD. And this did persist, although not statistically significant. The numbers became smaller. The sample size is less as time went on, as more patients' PDAs closed. But that risk persisted, that patients with more prolonged shunts were more likely to have BPD. The impact was not just BPD, just very briefly. Here you can see that after stopping prophylactic indomethacin, the incidence of refractory hypotension was increased, and that was associated also with the presence of a moderate to large PDA. The only trial of placebo-controlled trial of early therapy that kind of has recently been published that looked at kind of meaningful clinical outcomes was Martin Klocow's DETECT trial, which looked at infants who were randomized, but just randomized on the basis of diameter, which is probably a little bit too simplistic in trying to appreciate the volume of the shunt. Nevertheless, the administration of early targeted indomethacin reduced pulmonary hemorrhage, reduced late therapy. It did not change the primary outcome, but was underpowered for the primary outcome, as in Australia, they ran out of indomethacin. But one of the interesting things for me was this significant, although not statistically significant, there was a threefold reduction in severe interventricular hemorrhage. And when I moved to the University of Iowa in 2018 to this incredible program with so many tiny babies surviving, this suddenly became a concept we were interested in. Because although those babies survived, up to 25% had significant interventricular hemorrhage. So I just want to take you for a couple of minutes on a slight tangent, which is what is the relationship of shunt to interventricular hemorrhage? And what is the cardiovascular argument for modulating flow? We know that low cardiac output in the first few hours of life is associated with bad hemorrhage. This is some data from Shahab Nouri's non-invasive cardiac output monitoring study. Babies who have stable cardiac output for the transitional period did not get IVH. Babies who started off with low cardiac output that increased rapidly in the first 48 hours of life were more likely to get severe IVH. So how might IVH be modulated, at least in part, by the presence of a large PDA shunt? Well, as mentioned, after birth, you remove the placenta, which is a low resistance capacitance organ. The left heart is now having to pump blood against a higher resistance, so you will have a low flow state. However, if the ductus remains open, as pulmonary vascular resistance falls, you're going to have an increase in the left to right shunt. You're going to have an increase in pulmonary venous return, so your cardiac output is going to rise. That cardiac output will be preferentially delivered to the brain. So the question is an open shunt with, as PVR falls, is that modulating an ischemia reperfusion event? And what's particularly interesting about this argument is if you think of the early trials of surfactant, nitric oxide, high frequency ventilation, all of which change PVR fairly radically, all were associated with an increased risk of IVH. So this is our hemodynamics room at the University of Iowa. We now are up to 3 echo machines. We have 4 faculty. We do kind of 90% of all the imaging work in the NICU. We do over 1,200 consultations. And as mentioned, this question to me became incredibly important. How can we better provide stability for the circulation in that first 24 hours of life? So we screen all our tiny babies and have done this now for over 18 months. And based on the physiology, we provide physiology-specific care. So if there's heart dysfunction, we will manage that. If there's pulmonary hypertension, we will manage that. If there are moderate to large PDAs, based on our echo scoring system, which again is comprehensive, we will use Tylenol to modulate the shunt. This is a score that we use. And if the infants have a score of more than 6, which reflects a moderate to high volume shunt, we will provide early targeted intervention. Why Tylenol? Well, part of the reason for Tylenol was internal concern. We use prophylactic hydrocortisone for the first 48 hours in many babies, so concern about the potential risk of intestinal perforation. But also, if you look at Shobik Mitra's kind of heat map study, kind of Tylenol kind of seemed to be a strong predictor of modulating vessel size in the first few hours of life. And what's particularly interesting about how Tylenol works is this is some work we conducted in Toronto where we looked at the impact on pulmonary vascular tone. We know from another study we did with Jeff Reese several years ago that it takes incredibly high doses of Tylenol to vasoconstrict the ductus. But what you can see here is that it has a vasoconstricting effect on the pulmonary vascular bed. So we believe that the reason Tylenol is working is that it's keeping your pulmonary vascular resistance a little elevated, which decreases the transductal pressure gradient and decreases flow across the duct to allow spontaneous closure to occur. So what's been our experience? And we've now studied over 150 babies. Okay, let me talk about some of the findings. So first, only 40% of patients actually have a ductus that's concerning. And these are babies less than 27 weeks gestation. I forgot to mention that. We don't screen the older babies on day one. So that up to 40% of patients actually have a relative contraindication, one could argue, to PDA closure. They may have heart dysfunction, they may have pulmonary hypertension. So closing those PDAs with prophylactic indomethacin may induce harm. If we look at the primary reason for doing the study, this graph on the top right shows interventricular hemorrhage. The green is the Vermont-Oxford network for babies less than 24 weeks. The yellow is Iowa before the program. The orange is Iowa after the program. So you can see that even though our survival rates are much higher for tiny, tiny babies, our rates of severe IVH are the lowest in the network. Even for babies less between 24 and 26 weeks, you also see a very dramatic reduction in the instance of severe hemorrhage. Now, why is it relevant to today's talk? Well, it's relevant to today's talk because one of the two surprises we got were, one, a fairly substantial reduction in the instance of severe BPD and a substantial reduction in the rates of necrotising enterocolitis, such that our rates of NEC are only 1% now, which were unintended, unanticipated benefits of early targeted intervention. Our use of dopamine was reduced by 90%, our ligation rates have fallen. So again, this is not a randomized controlled trial. This is a single site center which has introduced a program in which we are now monitoring the impact of that program. But there is so much standardization to this, I think this data carries a lot of value. The final thing I want to mention is, and again, this is an important concept when thinking about trials, is when you randomize patients to a therapy, has it actually achieved its goal? And we have translated, again, based on the meta-analysis, the lack of efficacy of studies from the 70s and the 80s and 90s into PDA is not a problem, okay? However, medical therapy doesn't always work. And we have a manuscript that is going to be coming out soon, which is a post hoc analysis of a randomized controlled trial that we have just published as a feasibility trial, looking at early targeted intervention based on our PDA score. And again, small sample for the original trial. It was a pilot trial, 30 patients per group. We did not see a reduction in the composite outcome, not surprisingly. However, if you look here, and again, granted the numbers are small, in patients in whom early targeted intervention was successful, meaning by day 7, the ductus was closed, compared to patients in whom you failed with medical therapy or the patients who got placebo, you can see that the patients who had intervention success had the lowest risk of the composite outcome and also BPD, suggesting that solving the problem early is important. And again, we've already talked about the Shana study. How can we definitively solve this problem becomes important. And one of the potential solutions to definitive closure is percutaneous device closure. The percutaneous device closure data provides some additional interesting insights. This is some work from the Memphis group, who have got the largest experience kind of in the world. And because they do cath closure, they can also look at the pulmonary vascular bed. And what they found was patients in group 3 who reflected the most prolonged exposure to PDA, more than 8 weeks, at the time of cath, had much higher PVR. And after cath closure, their time to respiratory recovery post-procedure was much more prolonged. Again, adding to the evidence that we have to be careful with prolonged exposure that we're increasing the risk of dysregulated pulmonary vascular disease. We're potentially contributing to more chronic pulmonary hypertension that can make the management of these patients much more difficult. This is unpresented data at this point in time based on an abstract we've just submitted to PAS here at the University of Iowa. And again, this is based on our surgical data, where we look at all babies after PDA closure in the first hour, and we provided targeted prophylaxis with milrinone based on echo evidence of heart dysfunction. Important to remember that cath closure, it's not a benign thing at least from a lung perspective. We did not see any major hemodynamic instability after the administration of targeted milrinone. However, you can see that the patients, many of them, still had a late increase in FiO2, a late increase in their respiratory severity score, suggesting that, probably related to LV pressure and pulmonary venous hypertension, there are still major physiologic changes that go on after PDA closure. And this is the echo data that bears that out, that again, 1 hour after closure, there is still substantial impairment in, and this is left heart function. Again, you don't need to know about these measurements, but several measurements showing both with conventional echo and advanced strain analysis that LV contractility is significantly impacted. And these graphs over here reflect the stress velocity relationship, which is how much does afterload explain the impairment in heart function. And the slope of these lines is significantly increased, suggesting that afterload truly is the major determinant of LV dysfunction in these babies. So to wrap up, PDA is associated with major neonatal morbidity. However, an imprecise, indiscriminatory approach to treatment is not beneficial. I believe that there is a target patient population. It's most likely to be seen in the smallest babies. I think the money is in babies less than 25 weeks gestation mostly. However, there are babies at 26, 27, and 28 weeks that may benefit from PDA closure. However, I believe early targeted intervention is the way to go. There is still meaningful data to show an improvement in pulmonary hemorrhage and latent need for therapy based on randomized trials. However, late medical therapy is only effective in 50% of cases. Enhanced diagnostic precision with careful identification of the patients of interest with early targeted intervention is probably most likely where we're going to find a meaningful benefit in terms of BPD. However, word of caution, when we think about BPD in the year 2021, we need to recognize that not all BPD is just lung injury. We need to think about pulmonary hypertension. We need to think about systemic hypertension with pulmonary venous disease. And we also need to think about shunts like ASDs and PDAs. So I thank you very much. I hope people enjoyed the presentation, and I am going to be, you can see I'm in scrubs. I'm going to go off and have to do my rounds now, but I will join everyone hopefully for the moderator session in a couple of hours. Thank you very much.
Thank you very much, Dr. Patrick, for a wonderful lecture. So as Dr. Patrick said, he will go for rounds and he will be back after 2 hours for the question and answer session with the moderators with the panel. So now to move forward, I would like to request Dr. Junaid to introduce the next speaker.